Hello everybody, my name is Raisha Nurani. I'm a GP ST3 in London and I've been doing a series of CSA videos really trying to help you pass. Now this video is all about the last 5 minutes of the CSA consult and actually the previous videos were about the first 5 minutes and a general sort of overview of the entire CSA process. So if you haven't seen those, I would probably have a look at that first because this won't make any sense without having seen some of the other videos before. So we're going to talk about management and the last 5 minutes and how to use your time effectively to get good scores on the management part of this examination. I think management is something that people find really hard and actually trainees really struggle with management. I know I struggled with management and so I'm hoping that I can give you a structure of how to approach management and then also some kind of tips to how to really increase your mark in that management stage of the exam. Now the first thing I want to talk about is this idea of commitment. And I say this because I think this is probably the reason why a lot of people struggle. So essentially you've done your data gathering, you have a fair idea of what's going on, you might not be 100% sure, which is okay, but then you need to start making decisions and committing to those decisions. And I think that is a really intimidating prospect as a trainee because you know, we're in this bubble, we don't always have to make decisions, and if we are unsure, there's always someone else to ask. So I think this is where your skills to make decisions really start to come out. So essentially, the most important thing you can do at this stage is commit to whatever pathway you're going to follow and decide. So that might be, okay, this is a medical emergency, this patient is having a heart attack, I need to send them to the hospital. That's your commitment, that's your pathway, and that is what you're going to follow. It might be, I'm worried this person has cancer and I don't want to rule it out. Perfect, I'll do a 2-week referral, that's my commitment I'm making and this is what I'm going to follow. So it's exactly the same. Once you've made a commitment, all these kind of extra niggly bits that are coming in, they kind of become a bit more background noise. And it's very difficult because if you don't make a decision about what you're going to do from here, what ends up happening is you get all these sort of confounding sort of factors which start to play and you get really confused and you're like, oh, maybe I should have referred it, maybe I don't need to refer it, how about I try this medication or that medication, whatever it might be. If you can't commit to the path you're following, you really struggle. So I think I've said commit about 100 times in the last few minutes, and essentially that is probably the biggest and most important tip that I can give you. Okay, so now you've made a decision, you've decided what you're going to do, you then have to explain it and talk about it. So this is where my structure comes in really handy. So it's literally a 4-part structure. The first is a 1-liner explanation of what the diagnosis is. The second is what are you going to do about it. Then you get follow-up. So when you're next going to see the patient, and lastly you've got safety netting, what to do if things go crazy and chaotic. Let's talk about explaining what the diagnosis is. Now I refer to this in one of my other videos, but essentially it's a 1-liner and you do not have time to do more than this. So essentially what you're doing is you've got a simple 1-liner explanation for pretty much most diagnoses out there. For the ones that you find difficult to recall, write them down so you remember them. So one I remember writing up was a Morton's neuroma. So this is a bundle of nerve cells which have become irritated and that's why you're getting this pain. We call this a Morton's neuroma. You know, it's something as simple as that. And that is literally how simple it needs to be because there isn't enough time to go through the pathophysiology, the prognosis and all of those things in a normal CSA consultation. So I would have that 1-liner. And you just do that for most of your cases. If the patient wants more or you feel like they want more, you may be able to give it, but I don't think that's something you would commonly see in a CSA exam. So that's your explanation, nice and easy. Now the second thing is, what am I going to do about it? So this is where I would do things like conservative, medical and surgical, and have them in the back of my mind. So I would say things like, okay, well, your cholesterol is high, so we've talked about losing weight and looking at your diet and exercise, so you're doing your conservative. And now what I really like to chuck into the conservative is this I have an understanding of what else we could do to help this person's lifestyle and their conservative measures. So that might be things like, oh well, this practice has subsidized rates to our local gym. Would this be something that interests you? Or one of our nutrition specialists at the surgery can talk you through some of the diet options that are available to you. And some of them are true, some of them are a little bit less true, but the fact is they could potentially be available to a patient. And your CSA is a generic surgery which hopefully is well equipped and doesn't have all the bugbears of an NHS where you can actually refer to things. So I don't know, if I saw an elderly person who seemed quite lonely, I would mention to them the surgery knitting club or our local gardening club, and just really play on that. Other things that I started doing as I revised more intently for the CSA is I started writing out charities, organisations that related to certain things. So for example, I would say I understand that it can be quite lonely being you're at home on your own. How about something like Age Concern? They have a really good befriending service. Someone can pop over for a tea and chat. Would that be something that interests you? Or bedwetting in children. Have you had a look at the website Eric? It's really good. It goes through a lot of things that you might want to try, and there's other parents on there who have similar concerns. Now, in my opinion, that sounds 100 times more slicker than, here's a patient leaflet, have a read of it, if you have any questions, let me know. It's much more individualized, it's much more personal, it's much more with the times, and actually, to be honest, it's probably more helpful as well to you, because that is what you can use then when you're seeing your own patients. So I pretty much had a support service charity event that was aligned to most things that might help patients. So that's what I always put in with my conservative. That's conservative, and then you talk about the medical options, and then you talk about surgical options if they are relevant. You don't even need to do all three of those. Although conservative, I think there's always room for. So I would probably do that anyway. But medical and surgical depends on where you are at in terms of how far you've gone with that patient. Now, when you explain to someone what you're going to do, a lot of trainees will talk about option sharing. And option sharing is all good and well. I think you need to make a judgment call as to whether this is an appropriate station for an option sharing. If this is an emergency, you're sending this person to hospital, I think you're having what we call a heart attack. This is something that's quite serious. I think we need to send you to hospital now. That's your one-liner and what you're going to do about it. You're not going to do conservative, and you're not going to option share. Other cases, obviously, there is much more scope for option sharing. Now, option sharing is not, and I repeat, is not, we can give you this medication or this medication or this medication. What do you want? That's not how option sharing works in practice, and that's too generic. So it would be something like, okay, I understand you're diabetic, you've been struggling with your blood sugars. At this point, we would consider starting insulin, and I know that this is something you're worried about and you're not keen to start. There is an option of another medication. This works really well, and it's something we could also try, but it comes with its own side effects. It can affect your kidney function. It can give you much more likeliness of getting a urine infection. So what are your thoughts so far? You've now presented the patient with two options. One of them, is the insulin. The other is the dapagliflozin, as an example. So I don't know, it's just something to think about. But basically, you've done option sharing, but it's much more tailored to what the patient's asking about and where they are in their health belief, health agenda, whatever it might be. And that's how option sharing works. So it's not just a list of X, Y, and Z and just pick one. You need to explain the pros and cons, and kind of relate them back to what the patients wants and expects out of the consultation. Right, so that's what you're going to do about things. Then you do follow-up. So what we'll do is we'll try you on this medication, let's say 6 months. Will you come and see me in 6 months, and we'll recheck your blood sugars and see if it's made any difference, and then reevaluate where we are from there. Does that sound okay? And then the last thing you're going to do is safety net. Obviously, if you notice that you're getting urine symptoms, so you're having stinging or burning of your urine, or you notice something else that's unusual, I'd rather you come and see me sooner rather than later. So come and see me if there's any other concerns, if it's, I don't know, a heart problem, if you notice that you're getting short of breath, that your heart is beating really fast, you need to seek urgent medical attention. That means coming to us, calling 111, or going to A&E over the weekend or in the evenings. And so what you've done there is you've then safety netted. The last two, follow-up and safety net, don't really take more than about 30-40 seconds. So I would aim to try and finish around 20 seconds past 9 or 30 seconds past 9, and then just do your safety netting and follow-up. And that's essentially the structure for management. So you see, it's actually really easy if you've got a nice structure and you've kind of made a clear decision. Now, what the point of making the clear decision is if it's clear in your mind, it's then clear for the patient. So how do you make your management, which is already quite a nice, easy structure, how do you get the top marks for that? And there's a few other things that I would probably suggest. The first is when you're, and I've kind of alluded to this already, when you're handing that nice clear message out to the patient, think of it like a present. So you've gift wrapped this lovely image of what you're going to do and how you're going to handle it and where we go from here. You're handing it to the patient. So really, if you've got a nice clear thought process in your head, make sure it comes across as a nice organized, box that you can just hand to the patient and they've got it to refer to. Now what goes along with that is it has to be individualized. Management, generic management options don't go down well in the CSA, and I don't think they go down well in real life. So what you're doing is you want to say things like, I know that you weren't keen on insulin, so these are the options. Or I know that you mentioned that you were worried that this is a heart problem, but actually I think this is more a musculoskeletal problem because I know that you were concerned about X, Y, and Z, and this is why I'm suggesting we do this for the management plan. Everything has to be tailored back, because what is the point of getting someone's ice if you can't then use it to get the patient onto your side and to be on par with your line of thinking? So it really has to be individualized. The second thing is I've given you this lovely 4-point structure to follow. What I would say is don't run through it. Chunk and check. So every time you do one part of it, go, okay, I think this is a Morton's neuroma, this is what it is. What are your thoughts? Does that sound about right to you? I don't think this is a heart problem. I think this is a musculoskeletal problem because of X, Y, and Z. How does that sound to you? And so you kind of know the patient's on there with you. And actually it breaks it up, because the issue with management is it can sound very didactic if you haven't taken time to sort of go through it. And you have time, because as you can see, management is not complex. It's actually a lot easier than taking a history. So actually you have the time, and silences and using time to sort of bring the patient back into the conversation is a really important skill in management. So chunk and check, make sure it's individualized, and literally just hand a gift of management to the patient. It's very nicely done. You've got everything where you need it to be, and the patient can really understand that, and it works well for them. So I hope that helps. The next I know that the last sort of few videos have been really heavy and intense. I'm going to try and lighten it up for the next few videos and just focus on particular cases. So we'll talk about genetics and we'll talk about information giving, as those are the two things that other people have mentioned that they'd like some information on. If you have any comments or questions, or you think there's a video that you would like to see, please let me know, and I wish you the very best of luck revising.